What if Ozempic is not just changing weight loss? What if these drugs are also changing cravings, alcohol intake, and the way the brain responds to reward? That sounds dramatic, but this is exactly where the science is starting to go. GLP-1 drugs like Semaglutide and Tirzepatide became famous because of weight loss. Most people know the names Ozempic, Wegovy, Mounjaro, and Zepbound because they seem to do something almost impossible. They help people eat less without fighting hunger all day. But now, researchers are asking a bigger question. Are these drugs only appetite drugs, or are they reward system drugs? A randomized clinical trial published in JAMA Psychiatry tested low-dose semaglutide in adults with alcohol use disorder. The study was relatively small, so we should not oversell it, but the results were interesting. People taking semaglutide showed reductions in alcohol craving and some drinking outcomes. So the idea is no longer just internet gossip from people saying, "I took Ozempic and suddenly I stopped wanting wine." There is now early clinical evidence that GLP-1 drugs may influence cravings beyond food. Why would that happen? GLP-1 is not only active in the gut, it also interacts with the brain. These drugs affect appetite, fullness, blood sugar regulation, and possibly reward pathways involved in food, alcohol, and other compulsive behaviors. In simple terms, GLP-1 may turn down the volume on desire, not delete desire, not magically fix addiction, but lower the intensity of the internal noise. Which is honestly impressive, because most people's brains around snacks behave like a raccoon discovering a trash buffet at midnight. But this is where we need to be careful. GLP-1 drugs are not magic. They are not addiction cures. They are not a replacement for therapy, medical care, nutrition, exercise, or behavior change. The alcohol studies are promising, but still early. We need larger and longer trials before anyone can say these drugs should become standard treatment for alcohol use disorder. And for weight loss, there is another problem almost nobody talks about enough: muscle loss. When people lose weight quickly, they do not only lose fat, they can also lose lean mass. Lean mass includes muscle, water, connective tissue, and other metabolically active tissue. But the muscle part matters a lot, because muscle is not just something you use to look good in a t-shirt. Muscle helps with glucose control, insulin sensitivity, strength, balance, aging, and metabolic health. So yes, losing fat is good. But losing too much muscle while losing fat is not exactly a wellness victory. That is just your body becoming smaller in a way your future self may complain about later. This is why a new research direction is getting attention. A Phase 2 clinical trial tested apitegromab together with tirzepatide. Tirzepatide caused significant weight loss in both groups, but the group receiving apitegromab preserved more lean mass compared with the placebo group. That does not mean apitegromab is ready for everyone. It is still experimental, and we need bigger, longer studies. But it tells us something important. The future of weight loss medicine may not just be about losing weight. It may be about losing the right weight. Fat loss without strength loss. Metabolic improvement without physical decline. A smaller body, but not a weaker body. So what does this mean if someone is using or considering GLP-1 medication? First, do not treat the scale as the only result. The scale is useful, but it is also a very dramatic little liar. It tells you weight changed. It does not tell you whether that weight was fat, muscle, water, or your will to live after reading nutrition debates online. Second, protein matters. If appetite goes down hard, people may undereat protein without noticing. That can make lean mass loss worse. Third, resistance training matters. Not just walking, not just being active, actual muscle stimulus. Lifting weights, body weight training, machines, bands, or structured resistance work. Your body preserves what it has a reason to keep. Fourth, track strength. Can you lift the same weights? Can you climb stairs the same way? Is your grip strength dropping? Are you feeling physically weaker even while getting lighter? That matters. Fifth, talk to a medical professional, especially if you have diabetes, kidney disease, eating disorder history, gallbladder issues, or are taking medication that affects blood sugar. Because when appetite changes, glucose control changes too, and medication doses may need adjustment. GLP-1 drugs may become much bigger than weight loss drugs. They may help us understand appetite, cravings, reward, addiction, and metabolic disease in a totally new way. But the hype has to be balanced with responsibility. A drug that helps people lose weight can be powerful. A drug that reduces cravings can be powerful. But if we ignore muscle, nutrition, and long-term habits, we are solving one problem while quietly creating another. So no, Ozempic is not just a vanity drug. And no, it is not a miracle button either. It is part of a bigger shift in medicine, treating obesity and cravings as biological systems, not just failures of willpower. But the smartest approach is not just weight loss. It is high-quality weight loss. Less fat, protected muscle, better blood sugar, better behavior, and better long-term health. Have you used a GLP-1 medication? Or have you noticed changes in cravings, appetite, alcohol, or energy? Share your experience in the comments. And if you want science without the usual internet shouting match, like, subscribe, and send this to someone who thinks weight loss is still just about eating less and moving more.